and you are on the Fuse webinar. We're happy to have you. Dr. Nakamoto is having a little bit of technical issues, so I'm going to kick it off, but hopefully he will be able to join us in a few minutes. So just briefly, we'll go over the welcome and overview. Again, this is the welcome and interview. We'll go over sort of what things will look like. And then I'll talk to you briefly about the overview of the Fuse program and compliance modules. Then Dr. Hijji will be talking about introduction to electrosurgery. Dr. Zoumpou, hopefully I said that correctly, will be doing tissue sealing devices. Dr. Weithorn will be doing integration of energy systems with other medical devices. And then finally, Dr. Nakamoto will go over surgical smoke and aerosol safety, fires, and burns. So before we kick it off, we just wanted to briefly go over that SAGES, which is the Society of American Gastrointestinal Endoscopic Surgeons, is the sponsor for this webinar. There are the vision of SAGES is reimagining surgical care for a healthier world. The mission is to innovate, educate, and collaborate to improve patient care. There are several values to SAGES, including inclusivity, innovation, service, excellence, global community, and of course, the unofficial value of fun. Truly, SAGES, for most of us who are on the webinar, it's our favorite organization, and there really is a role for everyone in SAGES. So if you are not yet a member, we would encourage you to join. Again, lots of benefits, but registration discount for the annual meeting, which is just around the corner in a few weeks. Cutting edge education and professional development, including webinars such as these. And then a wide network of surgeons, trainees, about 7,000 of us that you can connect with and share ideas with. There are many different membership categories. For most of you who are on the webinar, it would be the candidate membership. And then once you complete your training, you would become an active member. If you're interested in joining and are not yet a member of SAGES, we would encourage you to go to our website. And then we would like to remind you that our annual meeting is just around the corner. It's in Long Beach. Thankfully, the area where the meeting is being held has not been affected by the wildfires that happened earlier, towards the end of last year, earlier of this year. Our hearts do go out to our colleagues and their friends and family who have been affected, but hopefully we're looking forward to seeing you in just a few weeks. So with that, I'm just going to transition over to my PowerPoint about the compliance modules to get this kicked off. Okay. All right, hopefully you guys can all see my screen. So I'm going to talk to you about our hospital compliance modules. It's a brief overview of this program that was started probably about 4 to 5 years ago. For those of you who don't know me, my name's Ivy Haskins. I am an associate professor at University of Nebraska in Omaha, and I am the Fuse co-chair. So Fuse was developed through SAGES, and when the utilization of laparoscopy took off and laparoscopy became the standard of care, there was a dramatic rise in the number and complexity of energy devices on the market. And unfortunately, with the increased utilization of these energy devices, we also saw an increase in the number of OR fires with both direct and indirect patient injuries. So meaning that there were injuries that were diagnosed immediately at the time that they occurred, and then some that were in a delayed fashion, for example, when the drapes came off. Ultimately, providers don't know what they don't know about energy. So Fuse began to help educate surgeons on the safe use of energy devices. For additional information about the FUSE program and its benefits, there is a YouTube video sort of about the overview and additional background information. It features Dr. Madani, who was very influential and crucial to the development of FUSE when it first took off as a program. So to further support that there was a knowledge gap on FUSE principles, when FUSE was first starting, we asked 48 leading surgeons in SAGES, most of whom were either on the board or were committee chairs. They were queried about topics covered on FUSE or within the FUSE program. And interestingly, 31% did not know how to handle a fire. 13% did not know that thermal injury could extend beyond the jaws of a bipolar instrument. And 10% thought that a dispersive pad could and should be cut to fit a child. There's all sorts of other interesting findings, but while the initial FUSE program has been helpful to bridge this knowledge gap for surgical trainees and surgeons, many other members of the OR team remain unfamiliar with FUSE principles. So the FUSE program has extended from just the online didactics curriculum to include resident and education sessions, such as the one tonight. There's also a FUSE manual, and our newest sort of efforts have been focused on the hospital compliance modules. The original online curriculum includes 8 to 12 hours of online didactics. It's free for anybody who signs up. There are knowledge checks at the end of each module, which becomes a theme. You'll also see that on the hospital compliance modules. And then there's a FUSE certification, which many of the residents and fellows achieve for additional training certifications, as well as CME credits when you complete the online curriculum. There are currently 11 modules, and our committee is actively in the process of updating the modules and integrating more recent technology, including the robotic platform. There's a FUSE manual, and this was actually published before the online curriculum and includes many of the topics that are covered in the online didactics. And this is a picture of many of the original members of FUSE who kind of spearheaded the development of FUSE as a committee within SAGES. So the education sessions, there's resident webinars like the one tonight. There's a potential for integration and establishment of fellows courses for trainees who are specifically going into MIS fields. We're in the process of working with other SAGES committees to make that a possibility. And while we still do some teaching courses at our SAGES annual meeting as well as ACS, we've transitioned to really focusing on providing grand rounds with standardized presentations by our committee members, as well as extending and branching out to include teaching FUSE principles internationally. And then finally, the hospital compliance modules. So these started about 5 years ago. And the feedback that we were getting is that the online curriculum was not, it was not necessarily applicable to every member of the OR team. So the hospital compliance modules are really an abbreviated version of the full online curriculum, and it's dedicated to teaching the safety of energy devices in the OR. And it's really aimed for all members of the OR team. So it's not aimed directly at surgeons, but in addition, our anesthesiology colleagues, our surgical techs, our circulating nurses, and other members of the OR team. There's 4 modules which are included. Each of the modules, really, it should take about 20 to 30 minutes for the user to complete. Module 3 is really important for our anesthesia colleagues, and Module 4 was written in the COVID era, so really covers a lot of topics that are pertinent in terms of surgical smoke and aerosolization safety. The modules are meant to be interactive with a learning check at the end of each module. So for example, as we play this video, if you sort of put your cursor over number 1 or number 3, it should tell you exactly what component or, what the value is for, here they're explaining what the electrical surgical unit is. There's also voice, so it's narrated as well, in addition to you being allowed to sort of roll your cursor over the important components of an electrical surgical unit. Same thing here, Module 2 goes over fire safety, which we all know is extremely important. But unfortunately, a lot of people don't know the steps in, what to do when you have a fire in the operating room. Module 3 is implanted cardiac devices. And then again, Module 4 is talking about surgical smoke and aerosolization. So why does this matter? There was a pilot study that was performed at BIDMC, Beth Israel Deaconess Medical Center. And so this was a free service that anyone could sign up for. And it was free for 90 days. And it was uploaded into the existing platform. 380 individuals completed the modules, and the users varied significantly. So there were surgeons, nurses, surgical technicians, as well as residents that were a part of this pilot study. The survey responses were recorded for more than 99% of those who completed the modules, and 92% felt that the Fuse hospital compliance module taught them valuable information. They thought that it would result in a change in the setup or use of energy devices in the operating room for about 80% of respondents, and 88% responded that they are likely to recommend this compliance module. So it's a real sort of high sort of knowledge, but quick and easy for most members of the OR team to use. And if you are interested, or your program is interested in learning out more about the hospital compliance modules, we're happy to have, to go over these sessions with you in more detail. That's all I got.
All right. Thank you, Dr. Haskins. Sorry about the technical difficulties. Can everybody hear me?
Yep.
Perfect. I'm Kei Nakamoto. I'm Vice Chief of Surgery at Tokyo Bay Medical Center. I'm reporting to you live from Japan. And thank you so much for filling in for me, Ivy. So we'd like to talk to you about Fuse surgical energy today. We have a wonderful set of panelists. We'll start out with Dr. Talal Hijji, who'll be talking about introduction to electrosurgery. For the audience, please, if you have any questions, please write them in the chat on the Zoom meeting. So Dr. Hijji, please take it away.
Oh, perfect. All right, so first of all, thank you to the SAGES and to the Fuse committee for allowing me to present this topic. So I'll be talking about an introduction to electrosurgery, and my name is Talal. I'm a PGY3 at McGill University in Montreal, Canada. So first of all, speaking the language, so oftentimes when we're referring to the terminology, when it comes to electrosurgery, we use incorrect or outdated terminology to refer to some of the things that are important. So for example, Bovie, Dr. William Bovie was a great scientist, and he developed some of the earliest electrosurgery devices, but the devices that we use today are not the same ones. And what we should be calling them is the electrosurgical generator unit, or ESU. Cautery, we do not cauterize during electrosurgery. Cautery is the act of heating up an instrument and then using that heat to essentially burn something else, which is not what we're using or what we're doing with electrosurgery. Grounding pads, there's nothing grounded in our electrosurgical unit. There's no current running through the ground. I'll talk a little bit more about that. And monopolar or bipolar energy. So through the talk, you'll see that all electrosurgical energy is bipolar energy essentially, and monopolar or bipolar there are different instruments that can be used, but it's all bipolar energy. So what is an electrosurgical unit? The blue box in our ORs. This is a device that exists in many shapes and sizes, but essentially it serves the same function, which is to convert the low frequency energy that we get out of our wall sockets. In North America, it's about 60 hertz, into a high frequency voltage, typically 300 to 500 kilohertz. And this is the optimal frequency to achieve the desired tissue effects. And also, it's a higher frequency than that would depolarize our muscles and nerves, our patients' muscles and nerves, which we certainly wouldn't want during surgery. It also allows us to adjust power settings and to control the duty cycle through different modes, such as the cut and coag mode. And I'll talk about what that means in a few more slides. So how does this current affect our cells or achieve the desired tissue effect? In essence, when we apply alternating current to our cells, we are depolarizing or switching the polarity of the cell back and forth. The switch makes it so that the molecules inside the cells, electrolytes, proteins, oscillate back and forth, and that kinetic energy creates friction between the molecules, and that frictional energy leads to thermal energy, which increases the heat inside the cell. There are two basic waveforms that you can adjust through the ESU. We call them cut and coag, although these can be misleading terms. But essentially what cut is that it allows you to deliver a continuous, non-interrupted current through your active electrode that is low voltage. So here we set cut, we set it to 30, and on the oscilloscope, that orange triangle, we see a sine wave that is continuous, low voltage, and not interrupted. Compare that to coag mode, where the current that is delivered is interrupted. It's actually on almost only 6% of the time. The rest of the 94% of the time, there is no current being delivered. So it allows some cooling period between each pulse of current that is given. And to achieve the same power, the voltage is significantly higher when compared to the cut form. And I'll talk about how those two different waveforms achieve different tissue effects and thermal spread. Electrodes. So each circuit, in essence, has four basic components: the ESU itself, the active electrode, the patient, and then the dispersive electrode. There is no grounding because none of the current is being delivered back through the ground. This is a historic system that hasn't been used in decades, because it could lead to higher risk of current diversion and burns. The way the dispersive electrode works is that it'll take the current that is delivered through the active electrode, and it takes it back through a higher surface area, so that it leads to a lower current density. So the tip of your active electrode has a very high current density because of its low surface area. So this leads to the tissue effect of heating up the cells to high temperatures, whereas that same current comes back through the dispersive electrode and back to the ESU through a higher surface area with much lower current density and heat. So all radiofrequency electrosurgery is bipolar. Whether you're using bipolar instruments or monopolar instruments, you need two electrodes. The difference between the two systems is in a monopolar system, the two electrodes are separated and you have the whole patient in between. This can be advantageous and can allow more flexibility in delivering and for the surgeon to deliver the current in ways that can lead to different tissue effects. But there's also an inherent risk where you can unintentionally develop current, delivered current to unintended parts of the patient, or the current can interact with other things such as pacemakers and such. Versus there are different types of tips that could be used on a monopolar electrode, and essentially the smaller the tip, such as in a blunt or in a needle tip, the higher the current is going to be focused on a small tissue, small surface area, leading to higher temperatures on that tissue, versus using a ball which distributes more of the current across a higher surface area, leading to more coagulation, less cutting, which can usually used through fulguration and causing to lead to better hemostasis. Well, this is an example of a video where the surgeon is using a consistent power throughout, but when he touches the tissue with the flat part of the instrument, you get a coagulation effect, versus when he uses the sharp edge or the smaller edge, we get a cutting effect. So this is an example of how same mode, same power, but different tissue effects based on the surgeon's manipulation of the instrument. Contrast this to a bipolar system where the only part of the patient that is affected by the current is the part between the two active electrodes. So this can lead to less current diversion, but you don't have as much flexibility. This is typically used when sealing vessels, and it can be very effective in sealing vessels 3 to 7 millimeters wide. So this is kind of the meat of what I've been talking about. So tissue effects, and how can you as a surgeon, what can you alter to achieve different tissue effects for your patient based on what you're trying to get? And the way I see it, you have basically 4 things that you can alter, manipulate to get the desired tissue effect. The first one is your power setting, the setting that you're setting on the machine, the waveform, which is either coag, cut, or a blend. The speed at which you're moving your instrument through tissue, and tissue contact, which can affect your current density, how much of your instrument is touching tissue, or whether it's touching at all, because you can also arc your current 1 millimeter away from the patient's tissue to achieve certain tissue effects. And if you put this kind of on a scale, if you go low voltage, you use 100% duty cycle, which is your pure cut, and you're moving fast through tissue, you'll get the least amount of tissue thermal spread, and you'll only cut the tissue that is right at the tip of your instrument. Whereas on the other hand, when you use higher voltage, or when you use a low duty cycle, such as in the coag mode, and you go slower, you still get the cutting effect, but you also get more thermal spread to adjacent tissue, which can be advantageous when you're trying to coagulate deeper structures, as long as you're doing it purposely and manipulating these factors. Cooperative coagulation. So this means that this just means that you are pressing the jaws of an instrument against a vessel to bring both sides together and try to coagulate it, or to achieve hemostasis. And at least it was surprising to me to learn that it's actually more efficient or better to use the cut mode when you're trying to achieve this, rather than the coag mode. And I'll show you how and why. So when you're using the coag mode, you remember you're delivering pulses of current in an uneven way and this can lead to unevenly affected tissue and an incomplete seal. You could still seal the vessel, but it's not the most efficient or effective way. It can also lead to more caramelization of tissue, leading to the vessel sticking on your instrument, so that when you take it off, it can disrupt the coagulum that you've made. Versus using cut mode when you're trying to achieve coaptive coagulation, which is your lower voltage steady current, you can get a more even coagulation and a more complete vessel seal. The slide also demonstrates it nicely. So here we start with the oscilloscope. You can see that this is a coag mode, low duty cycle, multiple kind of fires of current can lead to uneven areas of tissue effect. Remember, these areas become they start to act like insulators, where the current can't pass through as easily because of the higher impedance in this tissue, versus using the cut mode while pressing the sides of the tissue together can lead to a more even spread and better hemostasis. And most vessel sealing devices, I think my colleague is going to talk about this, uses this kind of current. So all to say, cut is not always cut, and coag is not always coag. You have to understand what these different mechanisms are and how to use them. So mechanisms of electrosurgical injury. We'll get to the more clinical part of my talk, and I'll start with a clinical scenario. So a 52-year-old female with symptomatic gallstone undergoes an elective laparoscopic cholecystectomy. During the procedure, monopolar electrocautery is used for the dissection of the gallbladder from the liver beds in the usual fashion. And the surgery is uneventful. The patient is discharged same day. Post-op day 3, she develops worsening right upper quadrant pain, fever, and tachycardia. Imaging shows a bile leak with signs of thermal injury to the bile duct. She's admitted, started on antibiotics, and undergoes an ERCP with a stent placement. So what went wrong in this case? So the bile duct injury likely resulted from thermal spread or capacitive coupling from the monopolar device. And I'll talk about what these terms mean. The surgeon didn't recognize the injury, as thermal injuries may not be immediately apparent. Mechanisms of electrosurgical injury can kind of be divided into 3 broad categories, either from the dispersive electrode or current diversion or the active electrode. The preventing injuries from dispersive electrode, you have to make sure that the dispersive electrode is in uniform contact with the patient, because like we said, the whole way it works is that it's spreading the current through a high surface area. If it's partially disrupted, it can lead to potential burns. So we want to avoid placing these on bony promises or on metal implants or hairy areas where it might not stick properly, or adjacent to things that can conduct currents, such as leads or electrodes, any skin discolorations, or limbs with circulatory compromise. Modern ESUs have modern dispersive electrodes, which the way they work is that they have 2 separate areas, such that if it's partially detached, the machine is able to recognize that the current is not equal between those 2 areas, and it'll immediately shut off the machine. Some considerations for when you're placing the dispersive electrode on an infant. So you have to use the appropriate dispersive electrode size. There are different weight-based size for the electrodes, and generally if the child is above 30 pounds, then you can start to use the adult size. You want to use a larger surface area. So in pediatrics, we will generally place them on the back between the scapula and the sacrum. And of course, you never ever cut a dispersive electrode, and you never overlap it. It has to be all in uniform contact with the skin. So you'll never wrap it around a patient's limb such that it overlaps. Current divergence. So this is the second broad category and can be divided into insulation failures, direct coupling, capacitive coupling, or alternative site injuries. I'll go over each one quickly. Insulation failures. So you'd be surprised how many of these instruments that we reuse regularly can start to develop defects and in their insulation. And remember, these defects can be too small to even see with the naked eye, but the smaller they are, the more they can focus current and lead to high current density areas and a high potential for injuries. So we always have to inspect and monitor our instruments before using them. Direct coupling. So we do this on purpose when we grab something with a debate key and deliver current through it. But it can also happen accidentally when the current sparks to unintended tissue and leads to injury. One example of this is metal-to-metal arcings, such as in the case of delivering energy close to metallic clips on a staple line, for example, which can, these clips are small. Again, they'll focus your current in a very small area, leading to the temperature in the adjacent tissue to rise very fast and can lead to staple line leaks. Capacitive coupling. So what is a capacitor? It's basically when you have two conductors separated by an insulator, such as here, these metal pieces are separated by a plastic insulator. And capacitive coupling is when you get a stored electrical charge within the capacitor. This becomes especially high risk when you perform what's called open activation. So, for example, your hook is not touching any tissue, there's nowhere for the current to go, but you're activating the instrument. This can lead to electromagnetic charge to get stored within the capacitor itself. And then you could touch other tissue. It could also happen outside of the view of your camera and lead to injury. Alternate site injuries. This is from a case report where a patient was burnt through conductive elements on the patient's bed. That can also happen with like stirrups. Active electrode injury. So again, three categories of this: inadvertent activation, direct extension, or residual heat. Inadvertent activations, in my mind, this is like a never event. This just means that you've activated your instruments when it's out of view or when you didn't intend to. And if the instrument is lying on the patient's skin or their face, it can lead to burns. So please always use a plastic insulator when you're not using the instrument. Direct extension, especially in areas where you have close structures that are adhesed to each other with adhesions. You could be trying to deliver your energy to one area and have that current be carried to another area. Here, you could injure the duodenum. So you want to make sure you're always performing short activations of your electrode or avoid it altogether and use sharp dissections. And finally, residual heat. Certain instruments retain heat for a long time after activation has stopped. So with ultrasonic devices, for example, they can retain heat for up to 45 seconds. You have to be aware of that, and you have to avoid manipulating or dissecting tissues when your instrument is hot to avoid damaging structures that you don't want to damage. And that's it for my part of the talk. Thank you.
All right. Thank you, Dr. Hijji. That was a great presentation on electrical surgery. So now Dr. Theofano Zoumpou will be talking about tissue sealing devices. These are the devices we use regularly, ligature, harmonic, et cetera, et cetera. So Dr. Zoumpou, please take it away.
Good evening, everyone, and thank you for joining today's webinar. I am trying to pull up my presentation and get it to the first slide. My name is Fani. I am one of the PGY2s at Rutgers, New Jersey Medical School, and I'm delighted to present on the topic of tissue sealing devices tonight. Before we begin, I just wanted to apologize for not having my video on. I've been having some internet connection issues, and when I try to project both my video and the slides, there's like significant lag, so I appreciate your understanding. Alrighty, so tissue sealing devices. Tissue sealing is a fundamental component of modern surgery. It impacts efficiency and safety, and ultimately patient outcomes. And by the end of this presentation, I hope that you will be more able to understand the mechanisms behind tissue sealing devices. We just heard about them, but we will discuss them again briefly. Compare the different tissue sealing technologies, and also be able to review the clinical applications and outcomes. We'll also briefly discuss some future advancements that are promising to revolutionize this topic. So let's begin with the basics. Tissue sealing plays a crucial role in surgery. It ensures hemostasis, it can help us prevent leakage, and ultimately, of course, it can improve patient outcomes. Historically, surgeons have relied on sutures, of course, which can be very effective, but sometimes are time-consuming. Staples and clips that provide mechanical closure with rapid application. And energy-based sealing, which is a modern alternative that has significantly improved surgical efficiency and precision. The energy-based tissue sealing options include electrocautery, monopolar and bipolar devices, the advanced bipolar devices, and the ultrasonic devices. And we will discuss each of these in more detail in the next few slides. Now, let's break down the two fundamental mechanisms of achieving hemostasis. This is thermal energy and mechanical compression. So thermal energy works by applying heat to the nature proteins, and thus leads to coagulation and vessel occlusion. In contrast, the mechanical compression relies on direct pressure to stop bleeding. When it comes to the electrosurgical devices, we have two main types. We have the monopolar and the bipolar devices. The monopolar electrosurgery devices deliver current from an active electrode to a return electrode, or the pad, as we just heard about. They generate heat that we use for cutting and for coagulation. On the other hand, the bipolar devices confine the current between the two electrodes at the instrument tip. This is a picture demonstrating the monopolar and the bipolar technique. Again, for the monopolar, the energy travels from the tip of the instrument to the grounding pad. For the bipolar, it travels between the two tips of the two electrodes at the instrument tip. For the ultrasonic devices, these devices operate at actually impressive 500,000 hertz, and they use high-frequency vibrations to both cut and coagulate the tissues through the generation of mechanical friction. This technology generates significantly lower thermal spread compared to the traditional electrosurgical devices, and we can say that they make for a safer choice for delicate structures where precision is critical. The advanced bipolar devices, examples of which include the ligature and the Enseal that I'm pretty sure most of you are already familiar with. They combine controlled bipolar energy with mechanical pressure to help us seal vessels by creating a fused collagen matrix. What sets these tools apart is their ability to reliably seal vessels up to 7 millimeters in diameter reducing the need for additional sutures or clips, and of course, enhancing surgical efficiency. Both these technologies offer significant advantages in minimizing both thermal damage, but also precision, and they definitely are essential in modern surgical practice. Now, let's take a closer look at monopolar and bipolar energy. These two are definitely two fundamental modalities in surgical electrosurgery. For monopolar energy, these devices work, as we mentioned, by delivering current from the active electrode to a return electrode. And this allows for efficient cutting and coagulation over a wide area, which is a major advantage in general tissue dissection and hemostasis. However, the downside is a higher risk of thermal injury to the surrounding tissues due to a greater energy dispersion. Bipolar energy, on the other hand, is more precise because the current flows only between the two electrodes at the instrument tip, as we mentioned, meaning there's less thermal spread and safer application near vital structures. This type of energy is particularly useful and very frequently used for vessel sealing, and it is also widely used in neurosurgery, ENT, and robotic procedures as well. However, bipolar energy is in general less effective for large area dissection compared to monopolar energy. Regarding the advanced bipolar devices, these devices utilize a combination of vessel compression and radiofrequency energy, again, to denature collagen and elastin and create a secure and permanent seal. I think a key advantage of these devices is their ability to automatically adjust energy delivery based on the tissue impedance, thus preventing excessive thermal spread. Two widely used technologies in this category are the ligature and the inseal. Again, I'm pretty sure that many of you are familiar with them and use them routinely. The ligature provides more efficient vessel sealing with minimal thermal spread. The inseal incorporates that advanced feedback control and can adjust the energy output in real time for more precise and consistent sealing. From a clinical perspective, these devices offer several significant benefits. First of all, they ensure reliable hemostasis, effectively sealing vessels up to 7 millimeters, as we mentioned. Second, they minimize the thermal injury, reducing the risk of adjacent tissue damage, especially compared to the traditional electrocautery devices, monopolar, bipolar devices. Third, they enhance efficiency. They're faster, secure, and they contribute to shorter operative times very often. And lastly, they're versatile, and this versatility allows their use across open, laparoscopic, and robotic procedures. Next, let's discuss the ultrasound tissue sealing devices and how they compare to the traditional bipolar instruments. So these devices use high-frequency mechanical vibrations to denature the proteins and coagulate the tissues. And by converting the electrical energy into this precise mechanical motion, they generate frictional heat, allowing for both cutting and sealing. The result of all this is a coagulum that forms by disrupting the hydrogen bonds in the proteins, and they can effectively seal vessels up to 5 millimeters in diameter. A very well-known example of this technology is the harmonic scalpel. The key advantages include lower thermal spread. The ultrasonic devices in general have a thermal spread of just 1 to 2 millimeters versus 3 to 5 millimeters in the bipolar devices. They can also offer simultaneous cutting and coagulation ability, and this improves efficiency during dissection and there's no electric current that travels through tissue. And this significantly reduces the risk of nerve or muscle stimulation, unintended burns, or interference with other medical devices such as pacemakers. The limitations include slower sealing time, especially for larger vessels, advanced bipolar devices such as the ligature, higher cost. The ultrasonic shears are disposable and can be more expensive and less effective, and this modality is less effective for high flow vessels or vessels above 5 millimeters in diameter. Next, I have included a table that summarizes the difference between the different tissue sealing devices, which I think includes the important information that we need to know. So the basic differences have to do with the energy type, as we discussed, the sealing time, the thermal spread. It's higher with the traditional modalities versus the like more recent, modern, sophisticated ones. The vessel size, again, the ligature and the inseal can seal up to 7 millimeter vessels, the harmonic scalpel up to 5 millimeter. And smoke production, this is something that we didn't talk about very much, but traditional electrosurgery is produces the highest amount of smoke compared to the harmonic and the inseal that don't produce that much smoke. For the energy device selection in surgery, this depends on tissue type and surgical approach and key considerations such as safety and cost effectiveness. For example, for fatty tissue, the ultrasonic devices like the harmonic are ideal because they minimize the thermal spread. In contrast, for vascular tissue, it's better to use the bipolar devices such as the ligature, as we mentioned, because these provide more precise vessel sealing. For the surgical side, in laparoscopic or robotic surgery, for example, energy devices can allow more precise sealing in tight spaces where sometimes the maneuverability is limited. In open surgery, we definitely still use electrocautery and suture ligation, and these remain standard, but energy devices can enhance the efficiency and the precision sometimes. The bipolar and hybrid devices are particularly effective at minimizing unintended thermal spread. And for the cost, the more modern devices can be more costly, but while this high cost may seem concerning, it is often justified in complex or high-risk procedures such as oncologic resections or transplants where precision is essential. Furthermore, these devices can reduce the operative time and complications and can lead to long-term savings, making them more cost-effective in the long term versus the short term. So in summary, the right energy device and the proper selection ensures a more balance between precision, safety, and cost efficiency, and ultimately it can lead to the optimal surgical outcomes. Of course, we need to discuss some critical factors, complications, and limitations related to the surgical devices. First, thermal spread and collateral damage. We talked about that some tools like the robotic sealing instruments can unintentionally affect surrounding tissues, and this definitely underscores the need for precision and proper technique to minimize this risks. Next, the learning curve and ergonomics. Again, these devices offer great potential, but they definitely require significant training to optimize performance and avoid the complications. And in addition to that, prolonged use, particularly in complex cases, can lead to surgeon fatigue and hand strain, and these can affect both safety and efficiency. And lastly, the cost and accessibility. The disposable and advanced energy devices can have a very high price tag, which poses a challenge, especially in resource-limited settings. The hospital budgets and insurance reimbursements can also vary, influencing the device availability. And that being said, as we consider these tools, it's always essential to balance the costs with the improved outcomes, as we mentioned, because ultimately, the more sophisticated devices can reduce complications in the long term and provide improved outcomes. So to summarize, the advanced energy technologies enhance both efficiency and safety in the operating room. They help us reduce bleeding, they have shorter operative times, and they minimize complications such as hematomas or leaks. Each modality has unique strengths, and I believe that knowing the specific characteristics of each device can help us make the right selection, optimize precision, and ultimately optimize the surgical outcomes. Thank you very much for your time and your attention.
All right. Thank you very much, Fani, for this wonderful presentation. I think it's essential to know how these electrical surgical instruments that you use daily work. As she was talking about, ultrasonic devices like the harmonic or the sonicision are almost purely mechanical. They use friction between the two jaws to generate heat and seal tissue, whereas advanced bipolar device like the ligature uses an electrical current that goes between the two jaws of the instrument. An electrical current kind of seals, and there's usually a cutting function where you can cut the tissue after it seals. And the monopole devices, such as the Bovi, the electrical current doesn't travel through the jaws like the bipolar instrument, but actually travels to your body to the dispersive electrode or the Bovi pad. So the electrical currents go through your body, which means you do have to be careful in patients who might have medical devices such as pacemakers. And this is what Dr. David Weithorn is going to be talking about next, which is integration of energy systems between other medical devices such as pacemakers and ICDs. There was a question that mentioned about the kill time and the heat generated by the advanced bipolar devices versus the ultrasonic detectors. And as I mentioned, the ultrasonic devices generate a lot of heat because it seals using a mechanical friction. And so the kill time seems to be longer and up to 40 seconds. So you do have to watch out when trying to use that to dissect after you seal tissues. That's one thing to note. But again, it's very important to know how these instruments work to be able to kind of judge that. So Dr. David Weithorn, please take it away. Thank you.
All right, thank you. So, this section covers the integration of energy systems with other medical devices. It involves EKGs, and so I understand that's painful to most surgeons, and I'll try and keep it as light as possible. So just a brief overview, we're going to cover which implanted devices are affected by radiofrequency energy. We're going to discuss which devices can cause the electromagnetic interference. We can talk about steps to reduce this problem, both in elective and emergent settings. And then we'll talk specifically about cardiac devices because that's where it's most relevant for most of us. And then we'll also talk about how to pre-op these patients. So in terms of implantable devices, they're susceptible to electromagnetic interference. The number one thing we look at is the cardiac implantable devices, which is two main types, pacemakers and defibrillators, or sometimes they're in combo. But it's always worth remembering that there are things like deep brain stimulators, spinal cord stimulators, vagal nerve stimulators, sacral nerve stimulators, implantable infusion pumps, and cochlear implants that can all be affected. These things are less common and less relevant in emergency settings. And in terms of devices that cause interference, top of the list is monopolar energy. both for standard surgical instruments, laparoscopic instruments, and the endoscopic instruments, which we don't usually think about. Then bipolar instruments have less of an effect. Radiofrequency ablation devices also have an effect. Technically, EKG monitors do have a small current. RFID ones have a small current. Technically, fluid and blood warmers can have a small current. A lot of these smaller issues are kind of negated by more modern devices to have appropriate shielding. But it's kind of worth remembering these things, and always MRIs to put up there. And then another reminder, we just cover this, ultrasonic devices and microwave ablation do not generate EMI, and so they're safe to use. And then bipolar is always recommended above monopolar when it's appropriate. So let's cover some clinical scenarios to kind of hash out these points. If you have a trauma patient with an isolated neck wound and you take them emergently to the operating room, in secondary survey, you notice that they have a pacemaker of some sort implanted in the chest. You don't really know what it is. What are some early steps you can do to minimize any risk that you're going to cause? And so, like we said, if ultrasonic or bipolar are appropriate, then it's helpful. For trauma, ultrasonic seems kind of weird, but you can absolutely set up the bipolar. And honestly, bipolar works really nicely in the neck if you've ever done thyroids that way. And then in terms of monopolar devices, you can take additional steps by not putting the lead such that the current pathway crosses the device leads. So maybe instead of putting the device out on the hip, you could put it up on the deltoid. And that's usually a large enough area with enough surface area that you can reduce that issue. And then, like we talked about in the first section, you can use the lower voltage cut modes, and you can avoid long activations. And then you can also reduce the power output to as low as clinically reasonable, to reduce the amount of interference you're causing to the device. Let's say you're taking one of these patients for a laparoscopic cholecystectomy. It's not an emergency, never an emergency. What should you do in the pre-op setting? So, first you should confirm that they have a device. History and physical will usually get you there. And then you should figure out what kind of device. Many of these patients carry ID cards. They might have medical records, or you can get a chest x-ray. And each of these devices has identifiable characteristics on chest x-ray. And there's radiology guides for how to determine these, and your friendly radiologist should be able to help you sort that out. And then you need to figure out if an electromagnetic interference is even likely for this kind of case. If you were doing a surgery on the person's toe, it's really kind of irrelevant. But for a laparoscopic cholecystectomy, your device will be within 15 centimeters of the lead or generator. And so that it is fairly close, and we need to think a little more critically about it. And then you should assess if the patient's pacemaker dependent. And I'll show you some EKG slides later, but what you're looking for is the pacer spikes that are with most or every QRS complex. And then, when it's a less than emergent situation, you should call your electrophysiologist or device representative to come and interrogate the device, figure out what the settings are, and adjust them as appropriate. We'll talk about that a little bit in the next couple slides. And then in here too. And then in terms of asynchronous mode, that's basically where you can set it so it gives a continuous output and never really detects for inputs. And so if the patient's pacer dependent, you don't want the pacemaker to accidentally think that your cautery signal is a heartbeat, or a patient generated electrical current for their heart, and therefore you want to set it so it continuously just delivers the same heart rate for the patient. And so if the surgical site is in the chest or the upper abdomen, it's a good idea to do that. So again, we're talking about asynchronous mode. The device rep, electrophysiologist is not present, and the device rep says, do you want this in asynchronous mode? So again, for pacemakers, the asynchronous mode keeps it delivering a constant rate, and then it prevents any detection, and that prevents incidental arrhythmias. This EKG over here kind of shows how you can cause stacking of the patient's own electrical rhythm with essentially pacer fires from misreading electrical surgical instrument signals, and you can induce a ventricular tachycardia. This EKG over here is just showing that the pacer spikes with each QRS complex. Going back to the text, there's another kind of device, the defibrillators, and what you do when you put them in the asynchronous mode is you prevent the tachyarrhythmia detection. So if the patient is prone to arrhythmias and needs or is at risk of essentially a ventricular tachycardia requiring defibrillation, you're turning that device off. And so that is helpful if you don't want that to happen. But when you do that, you should really think about what your anesthesiologist needs to have prepared just in case that happens to the patient while their implanted pacemaker is not available. And so that usually means is if a patient is prone to this problem, you should put pads on them before you prep and drape. So that way the anesthesiologist has the option to defibrillate them, God forbid something were to happen, even though it's probably not that likely. The time to do it is before you get into the surgery. So if you have a patient with one of these devices and you're going for an emergent surgery, like a perforated ulcer, and you do the usual steps. You put the cautery on the thigh as opposed to up towards the chest. That way the cautery current, the vector is pointed downwards. And you get bipolar, so really a ligature in this case probably. And then you think, what other steps can I do to minimize the risk here? So the person needs to go to the OR, but not so fast you can't get an EKG. So get the EKG. You can figure out if the person is pacemaker dependent. And then you can get a chest x-ray or check the patient's records and figure out if this is a pacemaker or a defibrillator. A combination of the EKG, seeing the pacer spikes, and also the appearance on chest x-ray or their records or ID card will help get you there. And so that's kind of the first steps you should do. And I mean, this takes very little time and is absolutely necessary. And then you should think about what interventions you can do. So one thing we commonly do is the magnet. It's the middle of the night. You can't get someone in to reprogram the device, so you can put a magnet on the device. What does the magnet do? Generally, for pacemaker, it puts in asynchronous mode, and for a defibrillator, it disables the tachyarrhythmia therapy. And then, like we discussed before, you should think that if the patient is at risk for an arrhythmia, and that's why they have a defibrillator, then you should set up the pads, the defibrillator pads, before you prep and drape, and have the defibrillator available for the anesthesiologist. So that way, if anything happens in the middle of surgery, you don't have to then take down your surgical drapes before you can even start caring for the emergency. A word of caution, you don't want to be defibrillating when there is a wet alcohol-based prep. And then you should also avoid placing these pads directly over the devices. You should place them around or on the sides of them to avoid damaging the implantable devices. This is an interesting scenario that can happen. If a patient is undergoing surgery and then during use of cautery, the patient's pulse ox stops, but they continue to have some signal on the EKG. The question is what's happening, and what's happening is that the pacemaker is reading the electrosurgical interference as cardiac activity and is not delivering cardiac contractions, and so the patient's actually going pulseless during cautery. And so you can see on the right hand side, there's a segment where the pulse ox tracing drops out, and during which there's this kind of noisy section on the EKG that doesn't really look like heartbeats, but it also looks like something's going on. And so the pacemaker is getting confused, and you're not really getting the patient's heart to beat at all. And so this is kind of one of the scary situations, and this is why we put pacers into asynchronous mode when they are pacemaker dependent. Another thing to remember to point out is that ST segment monitoring can be compromised. And so just trying to monitor ST segment based off of the anesthesiologist EKG leads is generally inadequate. Or also from like an ICU leads, and you generally need to have a 12-lead EKG if you are concerned about myocardial ischemia. So those are my slides. Thank you.
All right, thank you, Dr. Weithorn. That was an excellent presentation on implantable devices. Yeah, it's very important to note where your electrical current path is, meaning if your dispersive electrode and your bovie, where you're using the bovie, there's a path between those two. You don't want any implantable medical devices close to that path. You want the ICDs and the pacemakers as far away from the path as possible. It's always important in emergency situations to identify what the implantable medical device is. I think somebody told me there's an app that you can download. You can take a picture of the chest x-ray and it'll tell you exactly what the patient's implantable mechanical device or medical device is, which could be useful in determining your strategies. Worst comes to worst, you can always use sharp dissection and suture and ties only, or use an ultrasonic dissector, which does not have a current. All right, so next I will be talking about surgical smoke. I'm going to be sharing, hold on one second. Can everybody see my slides?
Yes, but it's on the phone mode, so it's very small.
It's small. Is this better if I turn it sideways?
It's more visible, yes.
More visible.
It's better, but we see like your head basically as the chat too.
Oh, so I just turn off my video, I guess.
The other thing is you could just have Betty advance your slides, maybe.
All right, let's do that then. If it's too small to see anyways. Let's see.
Can you see my screen?
Yes, perfect. No disclosures. Next slide, please. Oh, first one. Yep. All right, so let's go to a clinical scenario. You're performing a lap chole and your assistant starts venting the surgical smoke from one of the ports. Often happens all the time. Should you call for a smoke evacuator? Next slide, please. So this happens all too often. You see smoke coming out of the ports and you're like, is this good for me or bad for me? And there are smoke evacuators that you can use that look like that. So surgical smoke, the answer is surgical smoke's probably bad. Surgical smokes contain about 150 chemicals that are either toxic and or carcinogenic. So that's not good. And it also is shown to contain viral particles from HIV, hepatitis B, and hepatitis C. But there's never been, confirmed transmission from surgical smoke of these viruses. However, oropharyngeal lesions have developed after exposure to HPV ablation procedures. And, there have been experiments looking at surgical smoke and the particles, and you can see all these viruses in them. And for HPV, there's actually been documented transmission during ablation procedures, which is why you got to be very careful. In animal models, there's also been tumor transmission through surgical smoke. So there's cell particles within the smoke that they've identified, and that can actually kind of disperse through surgical smoke. Perioperative nurses also report 2 times the respiratory issues compared to the general population. And all in all, there's not been real hard evidence or proof of causation of these bad things happening, except for, but obviously, it's not good. So 18 states have passed surgical smoke evacuation legislation to mandate that you have to evacuate surgical smoke. Next slide, please. Yeah, so surgical smoke, as I explained, has inactive particles, can have viable cells, can have volatile organic compounds that are toxic, carcinogenic, can contain viruses and even bacteria. Next slide. And it's kind of important to note the particulate size. So the particulate size differs on what tissue you're cutting and what electrosurgical instrument you're using. The thing above shows you if the particulate size is less than 2.5 micrometers, so it's PM 2.5, then it can go to your lower respiratory tract. If it's less than PM 1, it can actually go to the alveolus. And if it's less than 0.1, it can go, these ultrafine particles can go into your bloodstream and disperse around your whole body. And the bottom left table shows you, depending on what electrical surgery you use, the particulate size differs. And electrical surgery, like the Bovie, produces the smallest particle size from 0.07 to 0.42 micrometers, whereas the ultrasonic scalpel produces the largest particle size from 0.35 to 6.5 micrometers. The particle size also depends on what tissue you're cutting. So lung, sub-Q fat, brain, and skin, these tissues actually produce the lowest particulate matter or particulate size. And then things like liver causes the highest, largest particulate size. So if you're doing, if you're cutting through subcutaneous fat with a Bovie or some sort of electrical surgery, that's going to produce much more smaller smoke particles that can, get into your bloodstream. Whereas if you're cutting liver with an ultrasonic scalpel, it's going to produce bigger particle sizes, which is kind of interesting and important to note. Next slide, please. So all in all, like I said, there's no direct proof or evidence that, surgical smoke caused anything except for HPV transmission. But even that, those are case reports. But obviously, it has 150 toxic and carcinogenic chemicals in it. It can cause headaches, eye, throat irritation, nausea, dizziness, cancer, potentially because it's carcinogenic. And, there's potential for disease transmission and tumor seeding. So surgical smoke is definitely not good. Next slide, please. And depending on the state you work in, you may have to use a smoke evacuator. At this point, there's 18 states that have passed surgical smoke evacuation legislation. This mandates use of surgical smoke evacuation systems during all procedures likely to generate surgical smoke. And, even in 2025, I think they added 4 or 5 new states to these surgical smoke evacuation mandated legislations. Next slide, please. So your state passed this new legislation that says you have to evacuate smoke or do some sort of smoke evacuation protocol for anything that produces surgical smoke. What measures can you actually take to mitigate risk from the surgical smoke? Next slide, please. First of all, you got to use things with OPA filters, not HEPA. The OPA has a better filtration, essentially. So, but most of these smoke evacuators use OPA. Next slide, please. There's passive evacuators where you hook up this little thing to the ports of your laparoscopic ports, attaches to the trocar, and the smoke passively leaves the abdomen due to pressure from the pneumoperitoneum. So you just got to open the port, and it kind of leaves and filters through this OPA filter within this little box. Next slide. And then I think this is more common, and I've seen more as active evacuation, where you attach to the trocar on one end and you attach to suction on the other end. So this is active evacuation. and it suctions. You can adjust the flow rate, the suction rate also to strong or weak, and this filters through an OPAL filter as well the surgical smoke within the abdomen. These are disposable. Next slide, please. And then there's sealed evacuation systems. This basically, there's continuous smoke evacuation and insufflation. So the CO2 kind of circulates and recirculates through this filter and this machine into the abdomen and out of the abdomen. So this filters as it's insufflating, so it's easy to maintain pressures when you're doing laparoscopic surgery. Problem is you can't just evacuate it, it circulates. So at the very end, when you have to kind of release the pneumoperitoneum, you do have to open your port, which means that if there's surgical smoke still in there, that's going to affect the surrounding air. And so what you want to do is wait until it circulates a couple of times, and there's all the air in the abdomen has been kind of filtered out. Then you kind of release the pneumoperitoneum. Next slide, please. And then there's things for open surgery, which is a little more difficult. These Bovie tips have suctions on them, on the tip. Next slide, please. And this is filtered through usually a suction system like this one. Next slide. So these strategies to kind of eliminate or reduce the smoke is the most effective. This is a hierarchy control, and this is basically eliminating smoke is the #1 priority. So using evacuation systems like these are the most efficient. The next one you can do is substitution, is basically once the smoke is released into the air, you want to kind of basically replace it with air, so dilute it, kind of. And this is done by the airflow systems in the OR. Next slide, please. So the airflow systems in the OR are kind of regulated pretty harshly. They're mandated to have 15 air exchanges per hour, which means 1 every 4 minutes. It's usually positive room pressure, where they push air into the room, and then the old air in the room kind of gets pushed out of these vents. HVAC systems have to be maintained, and the filters have to be changed. 5 minutes of electrosurgery raises the concentration from 60,000 to 1 million particles per cubic feet through the entire room. And because it takes 4 minutes, 15 exchanges per hour means there's an exchange of air in the room every 4 minutes. They say, after 5 cycles, it usually should be enough to kind of eliminate the polluted air, essentially, from the surgical smoke within a room. You got to be careful about these vents. That's where everything's being pushed. So if you're standing next to a vent, maybe you're an anesthesiologist or something, and you're close by, you do have to be careful of that, because that's where all the nasty stuff is going to be pushed to. Next slide, please. So that's elimination, and then we talked about substitution, basically diluting the pollution in the operating room air by pushing more air into it. Other controls that are less effective, there's engineering controls, reducing personnel in the OR, etc. There's administrative controls, educating the OR team, and developing protocols. And then least effective, there's PPE, where you wear face masks, face shields, which everybody does at this day and era. Next slide, please. And since this is SAGES, we'll talk about a little bit about laparoscopy and surgical smoke. Laparoscopic surgery involves greater use of energy devices, which means that it generates more smoke. It also involves insufflation, which means that it probably generates more aerosolization. So you do have to be careful during laparoscopic laparoscopy. More so. The thing is, though, it also can be made into a very nearly completely closed system. So if you deal with it well, it's actually beneficial. Next slide, please. So tips to avoid smoke in laparoscopy: use low insufflation pressures, obviously, and use the lowest possible surgical energy. These two are pretty evident. Next 3, you can remove the specimen after CO2 gas and smoke is filtered out. So like we talked about when you remove the specimen, when there's still smoke in the abdomen, that's all going to leak out. So try to wait until everything's filtered out before you remove it, or, desufflate the abdomen using an active smoke evacuator and then remove the specimen afterwards. Avoid suture closure devices that allow leakage of insufflation. You can still use it. I think if you give the smoke evacuation systems enough time to evacuate all the smoke out of the abdomen. Fascia should be closed after desufflation. If converted to open surgery, again, watch for there might be a lot of smoke inside the abdomen that might disperse into the air when you convert to open surgery. So make sure everything's filtered out before that. Next slide, please. Summary surgical smoke. Surgical smoke does contain a lot of harmful substances. Need to be conscious of strategies of elimination, suction, surgical smoke evacuators, etc. Substitution. Make sure you know the mechanisms of OR filtration of air, and use the PPE to reduce risks. There is more concern about aerosolization with MIS due to the insufflation involved and increased use of energy devices. So make sure you take appropriate mitigation strategies when you do so. Next slide. So lastly, I'd like to talk about OR fires. Why is this important? There's 650 cases a year in the United States. Whoops. We lost the presentation.
My apology. I don't know what happened. I'll put it back.
Anyways, there's a lot of fires, more than we expect and want. 650 cases that lead to injuries and potentially death in the United States. So we do have to be cognizant of that and make sure we do not have any OR fires. Let's see if I can get the slides up.
Can you see it?
I cannot. Can everybody else see it?
I cannot.
Oh, perfect. There it is. All right, next slide, please. All right, so here's a case scenario. You're excising a superficial neck lesion in the operating room. Anesthesia wants to do max sedation just with nasal cannula supplemental oxygen. You feel like this is a high risk for an OR fire. What should you be careful of to prevent OR fires? So face lesion, neck lesion, supplemental oxygen. Seems like trouble. Next slide, please. And you're right, this is trouble. 44% of OR fires occur in procedures in the head, neck, face, and upper chest. And something with an open oxygen source, like nasal cannula oxygen or face mask oxygen. There's a Anesthesia Patient Safety Foundation, the APSF, defines somebody at risk for surgical fire, somebody getting a procedure involving the head, neck, and upper chest above T5, and use of an ignition source in proximity to an oxidizer. So use of a Bovie or monopolar instrument close to oxygen is bad. So the first thing you need to be aware of is what procedures are at risk. You got to be able to identify, high risk for OR fire procedures and able to, prevent them in the first place. So anything in the upper torso, head, neck with an open oxygen source, bad. Next slide. Perfect. I think everybody's seen this fire triangle. For fires to happen, you have to have an oxidizer, either oxygen, which is probably the most common, or nitrous oxide that's used for anesthesia is also flammable. You need an ignition source, which is usually electrosurgery, like a monopolar electrosurgical pen, aka the Bovie, and then a fuel source, so flammable prep solutions, or even drapes or gauze can be a fuel source. Next slide, please. So strategies to prevent fires is built around this triangle. First thing you can do is just intubate or use an LMA, contain the oxygen so it goes directly into the trachea instead of kind of leaking out towards the surgical field. And if this is not possible, then you want to use supplemental oxygen less than 30%, which is like 3 liters nasal cannula if you think about it FiO2 wise. Also, drape optimally to minimize pooling or accumulation of oxygen and prevent it from flowing to the operative field. And I'll show you a picture of an example in the next slide of how to do this. Two, so in order to, kind of eliminate the ignition source, don't use electrosurgery. Turn off, or you can turn off the oxygen when you're using the bovie, or you can, at least try to use the lowest setting of electrical surgical setting possible. Alternatives, you can use ultrasonic devices also. 3, in terms of fuel, so try to use non-alcoholic skin prep and always allow skin prep to dry before starting the surgery. You can moisten gauze on the field so it doesn't catch fire and use flame retardant or resistant drapes. Next slide, please. So this is a example of open draping where the oxygen used through a nasal cannula does not pool underneath the drapes, which can then leak towards your surgical field and cause fires. Another thing you can do to prevent leakage of this pooled oxygen to your operative field is use Ioban also, is another thing that people suggest sometimes. Next slide. So if a fire occurs, what do? The first thing you got to do is kind of eliminate the source or the oxidizer. So you got to stop all flow of airway gases immediately. Then you remove the fuel or whatever is burning, drape, gauze, throw it on the floor and extinguish the fire using an extinguisher. Then you go to the patient. The important part is you got to control the fire first and then take care of the patient. So you control the fire, turn off the oxygen, extinguish the flames on the fuel, and then you pour saline over the affected area of the patient. Then you assess the patient, evaluate the patient, breathing and oxygen, need for further intubation, etc., and then to manage the injuries. So 3 steps below: turn off the oxygen, extinguish the fire, and then take care of the patient. Is crucial. This is very important to learn, I think. Next slide, please. Hopefully it doesn't happen to any of you, but there's another subset of fires called area fires where, this is a clinical scenario. You're performing a tracheostomy, an open trach, and you make an incision into the trachea using an electrical surgical pen, a bovie, and then an area fire occurs. What should you do next? This happens because, a lot of times high concentration oxygen is being blown through the ET tube into the patient's airway. And then when you use a bovie, that ignites the oxygen. This is very bad. Next slide, please. So what should you do? You got to stop all gases immediately. You got to eliminate the source, stop all gases, and you actually have to remove the endotracheal tube as soon as possible, because the endotracheal tube is serving as a fuel, essentially. It's going to damage the airway if you keep it in. So you got to remove the ET tube and other burning material, and then you pour saline down the airway. Once the fire is controlled, like usual, then you evaluate the patient and reintubate, and then manage the patient's injuries. That's very important to know. Next slide. So in summary, OR fires, first of all, you have to be aware of when you're performing high-risk surgery. So surgeries around the head with an open oxygen source. Try to intubate or use an LMA when possible when you're doing, when you're working on. If you're working on a groin, it's fine with, sedation or something like that. But if you're, excising a lesion in the neck or head close to the oxygen source, I would say, try to get the anesthesiologist to intubate or use an LMA. When that's not feasible, then you got to review these steps you can take to reduce the risk of OR fires. Do not make an incision into the trachea with a electrosurgical pen, bovie. Use, knife. When OR fires do occur, which hopefully never does, but like I said, there's 600 cases per year in the United States only. So you should know these steps and stop all gases, remove all burning material, including the endotracheal tube if it happens to area fire, extinguish all the fires, control it, and then pour saline over affected area, including, if it's the trachea, it's the trachea. If it's, neck, skin over skin, it's the skin. And once the fire is controlled, then take care of the patient, including reintubation. All right, that's it. Thanks, Betty, for doing the slides for me. So that is the end of our webinar presentation portion. If I guess we can get to Q&A. If the panelists can turn on their videos, I guess we can get on for the Q&A. I think we talked about the temperature differences when using an ultrasonic dissector versus advanced bipolar device. Yeah, bipolar uses current. Ultrasonic dissectors use heat, essentially, friction. Next question. When using electrosurgery, does pressing on the activating button or pedal in an alternating fashion, instead of maintaining a continuous pressure, decrease the thermal spread and or change the current that is delivered? Would be interested mostly in a situation where thermal spread can have severe repercussions, such as esophageal myotomy or dissecting on a PA. That's a very good question. We do this all the time instinctively when you kind of want to burn through an artery. You press the pedal multiple times instead of firing one continuous time. Let's see, Dr. Hijji, you did the electrosurgical portion. Do you have anything you can add to that question?
So I haven't really encountered this specifically, but in theory, yes, it should. I mean, you're allowing more time for cooling in between each activation, which should limit thermal spread to adjacent tissue. So in theory, it makes perfect sense, and that yeah, I don't have much to add to that. I think it should work.
Perfect. And anybody else that wants to add to that? All right, next question. If any alcohol-based preps are used, is there a rule of thumb as to after how many minutes electrosurgical activation is safe? I think most of my institutions that I've worked at, say 3 minutes for chlorhexidine chloroprep. It depends on the solution, I think. I think most of the time, though, it just depends on what it looks like and whether or not it's dry. It's visible if it's dry. Also, be careful of pooling. A lot of times it pools, let's say, in the umbilicus, and you got to dab that before you start and before you drape, essentially. Anybody else want to add to that? I don't think we used to say 3 minutes for chloroprep, but I think if it's still wet after 3 minutes, you should probably wait a little more longer. All right. Q&A. Comment. The fire due to alcohol-based prep can have light blue flame. In some cases, the fire was not even recognized. Yellow fire is more recognized. Yeah, this is something that people mention. I've never experienced the OR fire, and hopefully I never do. But OR fires, because the fires are it's alcohol lit up most of the time. Supposedly, they're very, very difficult to identify. So a fire could be actually happening, and you might not notice it. The fire might be happening under the drapes, where preps kind of dripped over or something like that. And usual fire is kind of orange, reddish. But supposedly these OR fires that happen from chloroprep based prep are kind of light in color, bluish, and very hard to kind of see. So you got to have high suspicion. Again, I think if you're doing any surgery in the upper torso, head, neck area with an open oxygen source, you just have to be aware that this is a high risk for OR fires. So thank you for that comment. Any other questions? All right. If there are no more questions, I think this is a great webinar. Let me plug one more thing. Ivy did the introduction to SAGES and all that for me because I was having some technical difficulties. But again, if anybody's not in SAGES yet, we welcome you. It's very inclusive. I'm Japanese and I'm working in a Japanese hospital. I just moved to a Japanese hospital from the United States a couple months ago. We have a strong Japanese contingency every year to the SAGE's annual meeting. They always have a big party at the end of the meeting, which is very, very fun. It's a little rowdy sometimes, but the Japanese group always does some sort of show on stage. We have a strong presence of Fuse in Japan. This is the Fuse book that was just recently published by one of our very own Dr. Watanabe. It's in Japanese and goes through Fuse. It's very, very nice, very detailed, and some of the stuff here. So, SAGES has a worldwide reach and very inclusive, very fun. It's, the only two societies I remain in is ACS and SAGES. And I think ACS is great, but it's very big and you can get lost. But SAGES, it's not a regional society by no means, but it's you get to know people a lot more. And I think it's worthwhile looking into it if you're not a member yet. So thank you very much, everybody. And thanks to the panelists and hosts for hosting this webinar. I hope you guys have a nice rest of your evening.
Yeah. Thank you, everyone.